So we're back to another part of my video about how to stop the spread of HIV. Now I'm focusing on MSM still in the first world, but I think the problem with gay bisexual men in the first world is actually quite similar to the problem of the spread of HIV in Africa and or in the black community. Now, I go through all the factors that increase the risk. Promiscuity, yes, of course, you may decrease your promiscuity if you wish, but maybe promiscuity is not even the very factor. I have a feeling that promiscuity is also linked to breaks between sexual activity that are longer. It is well known from sexual behavior studies that regular sex takes place in steady relationships. They have sex regularly, whereas people who have different sex partners and always new sex partners tend to have longer breaks between sexual intercourses. And the anus, as far as the main subject of the last video, bleeding, is concerned, or tears, small micro tears, the anus gets tight very quickly again if it is not used, and if feces are not well formed or compact or have are high in caliber. And this is also the subject I'm heading to in this video, because also in this video the main topic will be how to prevent the bleeding, how to prevent tears in your anus through which HIV and other infectious agents can enter more easily. Yes, that would be the next point. Other STIs, of course, seek treatment for if you have an STI. They increase the risk of contracting HIV, but also in the first place the question is, why do people who are more likely to catch HIV get STIs in the first place? In Germany, new infections with syphilis are in 80% in the gay bisexual community. Even syphilis needs small cracks in the skin. So you get syphilis a bit easier than you get HIV, so it has a higher potential for infection or for transmission. But even syphilis needs small tears in the skin to enter the body or the blood or the circulation. The skin is the most vital part of the immune system that you have. All the fancy stuff and all the various cells of the immune system and all the cascades that take place, all the signal proteins or interleukins that there are, they are very important and they do good work, but the most vital part of the immune system is the skin and the barrier to your blood. Still, if you have an STI, seek treatment. Be proud of your STIs. Criticize the doctor who appears to have an attitude like, well, if you have an STI, you're a pig. No, you can't be proud of it. You've shown a lot of love in order to acquire it. You deserve your STI. And you and your doctor, say to your doctor, of course I got it from love, and can we please cure it now? And also, all the other STIs except for HIV, they can be treated. With gonorrhea, there is some trouble now starting because the gonorrhea bacteria start becoming resistant to various antibiotics. But syphilis is a very nice disease because penicillin still works. The warts, the HPV infections, you can get vaccinated against them. All the other STIs, also the parasites, you have metronidazole and other stuff, chlamydia, macrolids help, and other antibiotics help. But HIV is the only thing that is bad among the STIs, among the sexually transmitted infections. But as I said, we should change our strategy here. That enemy is too strong. It is almost like an example, a very good example for human hubris to go on with finding a vaccine. I wouldn't say that finding a vaccine against HIV is an impossible task. It may be possible, but it's not the best way. It's like Captain Ahab in Moby Dick trying to catch and kill the whale that is too strong, especially when it seems that there are other strategies to prevent that disease. We have to consider that not everyone gets HIV. In the general population, the risk is almost negligibly low to catch HIV, and then the task should not be finding a vaccine, but finding out how the majority protects itself against the disease. Now, yes, you may say, well, maybe the vast majority protects itself against HIV because it has some intricate, complex immunological advantage over others. And this may also be the case because there is one theory that says Caucasians in general are less likely to catch HIV because Europeans experienced pestilence, the plague during the Middle Ages, and that's why 1 in 10 Caucasians now has some kind of protection against HIV. This is a known fact. About 1 in 10 Caucasians has some protection. He or she is not immune to the disease and can catch it, but even if he or she does, then the disease will not be so fatal, so strong, or so fulminant in that person. But still, these intricate immunological differences cannot be all, because even Caucasians get HIV if they are, for example, MSM or intravenous drug users. Now, for the intravenous drug users, the strategy to prevent the transmission is so easy that I will not focus on it here. Just use clean needles. But as for MSM, the route of transmission seems to be a little more complicated, or at least not so well understood, because otherwise we could prevent the spread. The same thing seems to be true in sub-Saharan Africa, where HIV/AIDS is really an epidemic. It's a almost general epidemic. HIV/AIDS also increases, the number increase in blacks in America. Just as in blacks in Africa, blacks are also one of the main victims in North America, the country of the first world, or so-called first world industrialized. I'd call it the dominating world that exploits the rest of the world. Now we have to find in detail the routes of transmission and block them. Try to make the bodies of blacks and of men who have sex with men in a way that resembles the bodies of that majority that is very unlikely to catch HIV. This should be the strategy for conquering HIV. Otherwise, it's fighting against Moby Dick. It's fighting an enemy that is too strong. There is no use in spending or wasting another decade for finding a vaccine, because still other viruses will come that use the same route of transmission. It's much more efficient to fight the disease by blocking the entry. This is a much easier way. It's like the captain who visits Captain Ahab in Moby Dick, who was also attacked by Moby Dick. Ahab has lost his leg because of the whale, and the other captain that visits him lost his arm. But when Captain Ahab asks him, well, are you not constantly looking for Moby Dick and chasing him and trying to kill him and get your revenge for your arm? He says, no, that whale is much too strong, and that hook, I like it, his iron hook, because I can tease young seamen with it. That should be our strategy in the face of HIV. Now, the other risk factor, depression, but what am I supposed to say here? Don't be depressed or what? Well, if we could do that just like that, would be paradise. Recreational drug use, yes. What should I say? How to prevent catching HIV? Well, use fewer recreational drugs. Seems just ridiculous to say that even. And now I will address the question how to avoid anal bleeding or small anal cracks that may not even bleed, but they are there and they provide an easier entry for the virus into the blood circulation. Now, I think, as I already mentioned in the last video, that anal bleeding or the occurrence of small tears or cracks in the anoderm, that is the skin of the anus, depends on the measure of the maximum atraumatic anal caliber. That is the maximum caliber that your anus can dilate to without tearing. And when I tried to find out and research about this physiological parameter, about this physiological variable, I found that there are almost no data around on it. Proctologists have been measuring the maximum squeeze and the maximum resting pressure of the anal sphincter complex by anal manometry. That's just what it is. Manometry means measuring the pressure. And proctologists do endoanal ultrasound to see the sphincter complex, as every proctologist or everyone familiar with anatomy, with the anatomy of the digestive tract will know. The anal sphincter complex consists of an internal anal sphincter that is built up by smooth muscle cells and of an external sphincter that has voluntary control, is skeletal muscle if you wish. So here we also see the limits of the term skeletal muscle, because in the external sphincter, in the external anal sphincter, it has 3 parts, and none of these 3 parts attach or insert into any bony structure. So it is not skeletal muscle in that meaning, but it is skeletal muscle cells that have voluntary control. Also, proctologists do radiological defecograms, and they may do other stuff, or may have done other stuff, but they do not examine or determine the most basic and most important functions of the anus. Proctology today is almost as prudish and ridiculous as gynecology used to be in the 19th century. Now look at this picture. This is a gynecologist in 1822 doing a vaginal exam on a patient. This is the proctologist of today. I am exaggerating, of course, to make that point. Yes, proctologists do the rectal exam with the patient naked, or at least through the openly exposed anus. But although you must usually tell them about such disgusting things as the consistency of your feces, most of them even fail to take a sexual history for receptive anal intercourse and or difficulty with it. This neglect can be somewhat tragic. There is a case report on a Belgian woman with a history of multiple colorectal operative procedures. Among others, 2 fissurectomies, 1 sphincterotomy, 4 ablations of hypertrophied anal papillae, 3 drainages of abscess, 5 fistulectomies, and so on. And it turned out that she had been anally abused by her husband for over 26 years, during which nobody asked her about her sexual history or even wondered somewhat intelligently where her proctological problems come from. Another study also seems to have evidence that 1 out of every 5 chronic anal fissures, that is a tear that does not in the anus that does not heal by itself and becomes an ulcer. It's also accompanied by hypertrophies or something like papillae, small lumps of skin around the anus. Anyway, that study seems to have found that 1 out of every 5 chronic anal fissures stems from sexual abuse. Now, back to the anal fissure, an interesting subject, because it is also common among men who have sex with men. Now, chronic here means an acute fissure sometimes or very often heals by itself, but once it becomes chronic, healing can be more difficult. Now, for the definition, chronic here means for most of the world that the anal fissure persists for a certain time already, more than a month or more than 6 weeks. But now Germans are wackos here, as in many other areas, and they define chronic. Chronic actually has to do with time, but they define chronic as having hypertrophies, as the presence of hypertrophies or anal papillae or lumps of skin around the fissure or ulcer that has developed. And also the Germans are wackos insofar as they here mainly cut it out. The therapy for a chronic fissure that does not heal with ointments and other conservative measures, the therapy is that they cut the fissure out. The procedure is called a fissurectomy. In the rest of the world, the standard treatment for a chronic fissure is to do a sphincterotomy. That is, not cut the ulcer out, but leave it and for a certain length of the anal canal, cut the internal sphincter so that the pressure of the anus decreases and the blood supply of the anus and anal canal gets better so that the fissure can heal because of better circulation, blood circulation around the wound. That helps heal the fissure. That is the theory behind it. Both treatments have a high rate of success, but the sphincterotomy renders up to 50% of the patients mildly incontinent, whereas the fissurectomy leaves an uncomfortable wound that takes months to heal, and even after that may look a little strange on the anus. I had an acquaintance, I'm just using that word because he used it about me in front of others, even after I had met him for more than 5 times. Anyway, I had an acquaintance once, and they obviously had taken his whole anterior commissure away, so that his anus looked more like a vulva, actually, than an anus. And when I once actually asked him whether he had an operation done on it, his answer even was that there was no operation done. Not even as a child. No, he had no operation. Maybe it's true, but maybe he didn't want to talk about it. But it was definitely not the natural aspect of an anus, and also looked somehow like scar tissue. But anyway, a fact is that many proctological operations carry a cosmetic aesthetic deficit with them, which brings me to a standard procedure for a pilonidal cyst. A pilonidal cyst is a cyst, sometimes filled with hairs, butt hairs, that grows between the sacrum and the coccyx. And still a standard procedure, there are alternatives now, but still a standard procedure done, is to excise the whole thing and not close the wound and let it heal over months by itself. And that leaves a large scar from the sacrum down to the anus. Actually, I just recently examined a patient who had it done last year, and it was a large scar, but he seemed okay with it, and that it's gone now. I mean, people are horrified when they do similar things to sheep in mulesing, but actually, people do it even to people, even if under anesthesia. So not only is proctology prudish and ridiculous, because they don't take a sexual history, they don't have data about the anal caliber, but it is also not really progressing and achieving better, more elegant results. I know that this is partly due to the fact that the icky anogenital branches of medicine don't get the financial support that they would actually need. But now, after this tirade, back to the anal caliber and what I could find about it in the few data that have been gathered about it. I asked myself, how do I find this measure? That is the measure of the maximum physiological dilation of the healthy anus that does not result in tears or cracks or paper cuts. And a first approximation of that measure, of that variable, I could find it in a study by Lester et al. From 1987, a long time ago. They determined in their specimen the circumference of the sphincter, of the anal sphincter complex. And this, well, why did they do it? That's interesting also. A standard treatment for anal fissure, for chronic anal fissure, used to be dilation. And actually it should be used again, in my opinion, because it is the best way to treat it. As I said, sphincterotomy carries a risk of mild incontinence, lasting incontinence, for flatus and sometimes also for feces. And fissurectomy leaves a scar, is uncomfortable, and takes a long time to heal. The standard treatment for a chronic fissure used to be dilation of the anus, but manual dilation was found also to cause some incontinence. Now they do dilation with instruments. Some studies did an anal dilation with smaller instruments, and these procedures turned out to be quite successful, actually. And because manual dilation turned out to be so destructive sometimes, as far as incontinence or tears in the sphincter were concerned, Lester et al. Tried to find out what the maximum atraumatic dilation of the anus is, how far they should go in dilating the anus in order to be safe, in order not to cause a rupture of the anus, a complete rupture. And that's why they determined the anal caliber in a dead specimen. They took 6 people who had been anorectally healthy during life, and they determined the circumference of their sphincters. Now, in situ, that is, in this dead specimen, they found a circumference of the internal sphincter of 6.03, well, you see it here, of about 6 centimeters, and they found a circumference, an inner circumference of the external sphincter of about 10 centimeters. The statistical the standard deviation was not very high, as you see here. Now then, they tried to, from there, get to the maximum dilation that is safe. And how did they do that? Well, other studies, physiological studies about muscle tissue, shows that the in situ length of smooth muscle is equal to 60% of the optimum length of that muscle for contraction. And for the skeletal muscle, that is the type of muscle that the external sphincter consists of, it holds that the in situ length is already about equal to the optimum length for muscle contraction. And then, from physiological studies about muscle tissue, we also know that the vulnerable length, that is the length where the muscle can be injured if you dilate it, the vulnerable length starts from 130% of the optimum length for contraction. And so we can calculate the vulnerable length, the length where where dilation gets dangerous, as 13 centimeters for the internal sphincter. 6 centimeters equals 60% of the optimum length for contraction. And so the optimum length of contraction for the internal sphincter would be about 10 centimeters. And so the vulnerable length starts from 13 centimeters. For the external sphincter, you have about 10 centimeters. 130% of about 10 centimeters is also about 13 centimeters. So the vulnerable length as far as the muscle, the sphincter muscle, the anal sphincter is concerned, is 13 centimeters, about 13 centimeters. That's safe to dilate until then. So that gives us a first approximation of the maximum atraumatic anal caliber. So now we have a measure. It's about 13 centimeters. This is what the muscle allows as an anal caliber. It's 13 centimeters in circumference, which divided by pi equals about 4 centimeters in diameter, exactly 4.138. So about 4.1 centimeters. This is what the muscle allows without rupturing. Now, a second variable also helped me in determining the maximum atraumatic anal caliber, and this surrogate variable, if you wish, was the maximum longitudinal tension-free anal caliber. And this is a concept that has been developed by Cho and others who tried to do controlled sphincterotomies. It's all circling around the subject of anal fissure, because this was the subject where I actually started research in proctology. I started my research in proctology on anal fissure, and at the same time had always been interested in HIV/AIDS, both in Africa and in the developed countries. And so now I found the link between the two topics. So Cho and others tried to do controlled sphincterotomies in order to cure anal fissures, chronic anal fissures. What they did was intraoperatively, during the operation, they measured the anal caliber that they achieved. That is, they did not do a standard cut through the anal sphincter muscle, through the internal sphincter, up until the dentate line in the anal canal. This is a measure or a landmark where that sphincterotomy, that cut in the sphincter, goes to the dentate line, or half the way to the dentate line, or only the length of the fissure. That's the length of the tear. These were measures to where the cut was made. And now they did a controlled sphincterotomy. How far they cut here, they determined by the achieved anal caliber. They determined how far they cut by measuring during the operation the anal caliber, how much they achieved already. So they put in cones that look like a bit like butt plugs. I can't show it here because I don't have the rights for the picture, but they look like butt plugs. It's a fancy instrument, actually. They were actually really developed for that purpose. They look like butt plugs, and they have lines on them, and they are inserted into the anus, into the anal canal and rectum, and then you can read the anal caliber. But they didn't go to the anal to the maximum point where then there is trauma. So they didn't test the maximum atraumatic anal caliber, because then they would have torn the anus or torn the skin at least. But they only determined the maximum longitudinally tension-free anal caliber. What is that? Well, they inserted that cone into the anus just until the perianal skin was just about to be depressed by the cone in the oral direction, so towards the body. They inserted it, and the anus remained in one. I have an animation which I show here. They inserted the cone just to the point where the perianal skin was just about to be depressed or drawn with that cone in the oral direction into the body. At first, the anus remained in one position, but then the whole anus was drawn with the cone or depressed by the cone into the body, and just where that point was, they measured the caliber. This is a surrogate for the maximum atraumatic anal caliber, which is probably, or which quite plausibly is even higher than the maximum longitudinally tension-free anal caliber. But this was a good measure, and they also determined that people who have trouble with their anus, who have an anal fissure in that case, a chronic anal fissure, that they have a smaller longitudinally tension-free caliber than do people who have a healthy anus. And my hypothesis is that the chronic anal fissure is associated with a relative stenosis of the anal canal. This is what they measured. They determined in an anorectally healthy control group, consisting of 40 subjects, an anal caliber, a longitudinally tension-free anal caliber of 34.6 millimeters. So 3.5 centimeters, 35 millimeters. And then, by subtraction of two standard deviations, this is the usual procedure for determining what's normal and what is not so normal, they took away two standard deviations, 1.4 millimeters, in order to define a relative anal stenosis. That is, an anal stenosis was defined as an anal caliber, a maximum longitudinally tension-free anal caliber of 31 millimeters or below that. And the fissure patients had an anal caliber, a longitudinally tension-free anal caliber of only 29 millimeters. And about 80 or more % of them had a relative anal stenosis, according to that definition, 31 millimeters or below. So this is part of the etiology or of the pathophysiology of an anal fissure, that your anus is too tight. So this was a hint for me that people who suffer from tears in their anus have an anal caliber that is simply too narrow, that is too tight. People who suffer from tears in the skin of the anus have an anus that is slightly, sometimes you don't even realize it in the digital rectal exam, but there is a slight stenosis in these people. Now, what did I also look at? I also looked at, in order to figure out what is that maximum atraumatic anal caliber, what is that physiological parameter, I tried to find out about the medium or maximum stool caliber of normal people. What is the medium, or for that matter, what is the maximum stool caliber that does not produce tears? So what can people stand as for the size of feces? And I found that there are absolutely no data on it. there are two classification systems for feces, and one is the Bristol stool scale that is based on stool drawings and on questioning many people in Bristol. And here you have that table. It shows some exemplary stool forms and consistencies, but the objective diameter of the feces was not measured is not measured in the Bristol stool scale, and was also not measured in the study that introduced the Bristol stool scale. It was just subjective information based on these drawings. They did not collect the stool, which is a pretty disgusting endeavor, I admit. But there was also there were some small studies where people did collect their stool and turn it in somewhere. But unfortunately, in these studies, the stool was measured in frequency, that is frequency of defecation. It was measured in volume, it was measured in mass. The consistency was measured by inserting cones into the stool, cones of various weights, and they looked how far the cones sunk in order to determine the consistency of the stool, but they did not measure the diameter of the stool. So there are no data around about how thick normal stools are. So I tried to look at a surrogate of the surrogate, if you wish, and I asked myself, well, what about people who have anal receptive intercourse? Does it have any consequence as for, well, continence function, anal continence, or on the anoderm, that is on the skin of the anus? Does it tear if people have anal receptive intercourse? And I did clarify that a little bit in the first video already, where we said that, I repeat, about a third of anal receptive men sometimes have bleeding. So sometimes have tears in their anus that even bleed. They realized it. That is the question that the researchers asked in the study. Do you ever find that there is blood on your anus after you have had sex, or that there is blood on the toilet paper after that? So we know that at least a third, or a third of men who have sex with men and who are anal receptive sometimes bleed, and about 10% or 7 or 8%, I think it was, bleed half the time, or even always, half the time to always. So some people have trouble, but the majority in the HIV negative group of that Copland study, the majority, 2/3, never bleed, so they have no trouble with tears. They have, in a way, an anus of the gods. That is what Cartman also says from South Park in the Chipotle Away episode, if I remember correctly. Yes? Not everyone can have a rectum or an anus of the gods, but the majority seems to have no problem with it, and that's what I would call a healthy anus. That also protects you from catching HIV. There is no bleeding. Now, what about the other studies about anal receptive intercourse that may tell us something about the maximum atraumatic anal caliber? Well, there are actually two. There are two studies about the consequences of anal receptive intercourse on sphincter function. The first is one by Miles et al. From 1993, and they said that dilation of the anal canal through penile penetration would have some kind of risk for mild incontinence. But wait. They found a decrease in electrosensitivity of the anorectal mucosa and a significantly reduced anal resting pressure in the anoreceptive men. And they also found in 14 out of their 40 anoreceptive men, they found mild continence problems. And these continence problems were only present in 1 of 18 non-anoreceptive men, their control group. But they did not really specify what that mild incontinence was. They did not differentiate between flatus and fecal incontinence, so that was in a way bad. More severe deficits in continence were associated with more traumatic forms of anal manipulation, that is, brachioproctic practices like fisting, so-called fisting. But there was a real problem with that study, and that is that the anoreceptive subjects of Miles et al. Were all recruited from the Department of Genitourinary Medicine, where they were in follow-up examinations and had at time of study no anorectal disease or anorectal any other dysfunction anorectally. The control group, however, was made up of heterosexual men without a history, without even a history of anal or rectal disease. So there was a clear bias. You cannot compare these two groups. The second study by Chan et al., 1997, they did not have such a bias. In their anoreceptive group, everybody was excluded who had a history of pelvic or anorectal operations or injuries, had any active anorectal or gastrointestinal infections, or took medication, or had systemic disturbances that affected anorectal tone or anorectal function. But now, well, also this study could have a systematic bias as far as the health effects of anoreceptive intercourse are concerned. But now this is what, because they excluded everyone with anorectal disease and so on, and so as a result they will probably not find that anal intercourse, receptive anal intercourse, leads to anorectal health deficits. But there is a systematic bias, but now this is at least one that is the same for the test group and the control group, which was not the case in Miles et al. And they also found, Chan et al. Found in their study that, well, the resting pressure of the 14 anoreceptive men was significantly lower than in the non-anoreceptive men, but they hypothesized that this is because the anoreceptive men are used to anal manipulation and so are more relaxed during measurement, and the other differences that they found were insignificant. The maximum squeeze pressure was not statistically different from the non-anoreceptive men, and the sphincter was only insignificantly thinner as compared to the control group. There was no real difference. Could have been explained just by chance. Endoanal sonography was normal for both groups, anoreceptive and non-anoreceptive. Lesions of the internal or external sphincter were not found in the anoreceptive or non-anoreceptive group, and fecal continence problems were not present. They, however, I should mention that, excluded flatus incontinence as a criterion of continence, because they said that it's of questionable significance and could hardly be classified as a pathology. Yes, what is a fart? Is that a disease? Especially if you don't hear it. That's also a really interesting subject, because you don't even have to determine the longitudinally tension-free anal caliber if you don't want it, because even that may be an uncomfortable procedure if the doctor checks how wide your anus can dilate. As an ersatz, if you wish, you can also try to evaluate the noisiness or the pitch or key of your flatus, because if that's rather low or not so noisy, then chances are that your anus is relaxed and wide, and you have enough skin that can be dilated to 4 centimeters diameter or caliber. But if it's a high-pitched fart or very noisy, then chances are that the anus is too tight and that it may tear when it is dilated by large stools or erected penises. So we see that the healthy anus should actually tolerate dilation of about 4 centimeters diameter. And this is actually exactly the penile diameter. This is the penile caliber, about 40 millimeters. Kinsey found that 29.4% of all whites with college education have a virile member which measures at least 13.3 centimeters in circumference at the thickest point. And this would be a caliber, a diameter of 42 millimeters. And the average diameters, the average calibers of the penis were about 12.2 centimeters for whites. With a college education, he differentiated between college, non-college, and blacks. Whites without college education had a caliber of 12.0 centimeters. I also have it in inches here, 4.72 inches. And blacks are a little bigger, 4.95 inches, 12.6 centimeters in diameter. And this is somewhat strange, because if you look at vaginal dilators that are used when females have problems with vaginal intercourse, if you look at sets of dilators there, sometimes they are not thicker, they are not larger in diameter than 35 millimeters or 40 millimeters, which is the average penis size. The average penis diameter is the greatest or the highest diameter that they have in their sets. And in some sets they even don't have the average penis size as a dilator. Now Diekman et al., for example, studied how many women experience pain or trouble in intercourse, and this is only in inverted commas vaginal intercourse. Actually, just a side remark, some people who are critical of the whole idea of anal intercourse, the anus is actually in many ways more appropriate or suited more for intercourse than the vagina, because the anus or the rectum has goblet cells. So inside, at least inside, not on the outside, that requires lubrication, additional lubrication, that is true. But on the inside, the rectal wall has goblet cells which secrete mucus for lubrication. The vaginal epithelium does not really have secretory cells. This is quite interesting. Although lubrication there is also important, the vagina does not have secretory cells that secrete mucus, where the moisture or the wetness of the vagina comes from the Bartholini glands in the vaginal vestibulum. And maybe there is some lubrication from cervical secretions, cervix mucus, and then there is some, kind of sweat. The term is transudate, or what happens is transudation. The vagina is kept moist by, in a way, sweating. The cells press some fluid through the epithelium, but the vaginal lining has actually no secretory cells. So actually the rectum is very suitable from nature for having intercourse. Also, it trains for intercourse daily through the feces. If the feces are well formed and if the feces are large and compact, then what the anus experience as a dilation, the function of the anus is not to close only, but the function of the anus is also to release feces and to open. An organ that closes and that holds back things is also, at least in case of the anus, also there as a natural purpose to open sometimes and release and widen. And an anus that is used to large feces is also automatically able to accommodate an erect penis and to give pleasure to the recipient and to the giver. But as I said, not everybody can have a rectum or an anus of the gods. And so those that don't have to take care of their anus and have to, if they wish, reach that healthy state. And now we see here that in this Stickman et al. Study that the vagina also has trouble, that not every woman has a vagina of the gods, because almost half of the women questioned here, women surveyed, said that they know severe pain during intercourse. And some women have dyspareunia, that is the term for painful intercourse, that is so bad that intercourse is almost impossible. There is also a bad joke from the House of God about dyspareunia, and this is actually the whole trouble with sexual intercourse and with hurting people through sexual intercourse, and at the same time making them more vulnerable for catching disease. The House of God, this medical novel about life in the hospital, there is a joke. Sometimes it is better to have dyspareuned than never to have pareuned. And this is what many people think about sex, both on the recipient end and on the giving end. Sometimes even the recipient, the receptive person, accepts that there will be some pain, because maybe he or she thinks that this is the way it should be, or this is the only way that it works. It's just necessary. But this is bullshit. So now to treat dyspareunia, some people use vaginal dilators, which are, as I said, sometimes even too small. Now, there was a study by Murina et al. In 2008 about vaginal self-dilation. Self-dilation is, in medicine, seems to be something that has a bad reputation. There are not many studies about self-dilation, but self-dilation sometimes really helps. Now, let me digress a little bit about self-dilation here and then tell about what Murina et al. Did. Self-dilation seems to have some kind of a perverse character to it. I don't know why, but it seems so. Self-dilation often helps. It helps with anal fissure. The people in forums about anal fissure, they also report that it helps them. Their music, or with their wind, or their flatus gets softer, and the fissure heals. I also suffered from chronic anal fissure, and I could cure it by means of self-dilation. Now, I should remark that almost all the medical anal dilators are way too small. As we saw from that CHO study, healthy people, anorectally healthy people, have a longitudinally tension-free anal caliber of about 35 millimeters. Now, almost all the medical dilators are at most 30 millimeters thick. Many are even thinner than that. So they don't help. They don't help you achieve the anorectal caliber that a healthy anus has. But if you go to erotic articles, if you use butt plugs or vaginal dilators, then you achieve the anal caliber that makes your anus suitable for large feces and for erect penises. I think that butt plugs are ideal because they have a conical or biconical shape, so the size or the diameter increases gradually. This is really an advantage. You don't have to go all the way abruptly, but it slowly increases in diameter, and then it decreases again. And this is when you know that you have achieved the highest diameter, that you have well overcome the highest diameter. Many medical anal dilators are not biconical. They are just one cone, and then you don't know yourself where you are, how far that dilator is in now, because you don't really feel it well. The butt cheeks are in the way. You don't really feel how far that thing is in. But if it's biconical, if it increases in diameter and then decreases again, then you know that you have achieved or that you have overcome the maximum circumference or diameter of the instrument. And this gives you confidence. Then you know that you can handle that diameter, a diameter that thick. Then you are confident. Now back to Murina. That's a good topic for Murina, self-confidence, because Murina, they did that study about vaginal dilators, and they used the product Amyl Comfort of Owen Mumford. They even mention it in the study. It's no advertisement. And they say that the Amyl vaginal dilators, beginning with a diameter no larger than 3/4 of an inch, that is 19 millimeters, range upward gradually to the size of a man's fully erect penis. Yes, I think this is really this is insolent or even mean what they say here, because I checked at Owen Mumford at the how thick the Amyl Comfort dilators of Owen Mumford are, and that firm says in their product brochure that the maximum caliber of their dilators is 35 millimeters, 3.5 centimeters. So this is not at all the size of a man's fully erect penis, at least not the average man's fully erect penis. 0.5 centimeter is missing there. So this is really mean what Murina et al. Do here in their study. 0.5 centimeter is missing in diameter, and that means for the skin, for the circumference, that times pi, that almost 1.5 centimeters are missing there for the real thing, for an erect penis. And this I find really mean. Because if you think of the vagina or of the introitus vagina or of the vaginal introitus as a model as a circle, as a cylinder, then, as I said, in circumference 1.5 centimeters are missing. And when the woman is suffering from vaginismus, or the vaginal introitus is somewhat atrophic or thin, tight, narrow, then there may be, when the woman tries having intercourse after training with these Amyl Comfort dilators, then there may be a tear of theoretically 1.5 centimeters in width. So this is really, this is mean. This shouldn't be done, what they did. They don't have a sense of reality, and they provoke, by doing such things, they provoke pain and trauma instead of giving confidence to the woman when trying sexual intercourse again. I did a clinical traineeship in urology, and during that I had the honor to attend a conference on urology, a national conference of urologists, and I even met there someone who actually made these vaginal dilators, and he also had some with him and presented them to the urological audience there. And I also asked him, well, how come that your largest dilator here in your set is only about the average diameter of the penis, the largest one, or even in some sets the largest dilator is not even as large as the average penis. How come? Why do they do that? And he said, he was obviously a fag, by the way, but this is what can almost be expected. If you have trouble with intercourse and with the receptive part of it, don't go to other gays or to females for support, because they usually don't give it to you. Maybe because they had bad experiences themselves and nobody helped them, and nobody gave them comfort, and well, they somehow had to deal with it, and now you have to make the same bad experiences. People are really mean, and this is what he said. He said, well, if you achieve 35 centimeters or 30 centimeters, then it's not much more to go. You don't have much more to the dilation of a real penis will not be that much more. But this is, again, I think utterly mean. Because if you do sports, or if you have a competition and you practice for that competition, you want to be confident. If you want to achieve in an exam or in a competition, if you want to really know your stuff or really achieve your goal of maybe, well, to go as high as 4 meters or 5 meters, then or would like to get 90% in an exam, or at least 80% in an exam, then when you study or when you practice, you make sure that you will get at least 90 or 95% sometimes, and not that you practice achieving 80% and then hope or are forced to make or to achieve 95% in the exam. That's ridiculous. You want to be self-confident. You don't want to encounter any surprises or be shocked when the real work or when the real situation comes. Now let me talk also a bit more about dilation, about the important thing that I found, and also why dilation, why self-dilation above all, can be very fruitful in medicine. Self-dilation is also important at the other end of the digestive tract. Some people who suffered from esophageal cancer and who had an operation of the esophagus, where the esophagus was shortened, or where the esophagus was radiated, or some people who have metastatic cancer of the esophagus, people who have esophageal stenosis, wherever it may come from. A good way to treat that is by self-dilation of the esophagus. People put something like a snake, a rubber snake, into their pharynx, into their throat, swallow it down, and by that they regularly dilate the esophagus. This is not very commonly used, but there are even some YouTube videos about it. If you search for it, it's quite interesting, and I admit that also seems a little bit ridiculous or even perverse. It seems like a joke, when they show that self-dilation of the esophagus, that it really helps. What in endoscopic, what people do that don't like the self-dilation is they go in monthly intervals or a 3-month intervals. They go in with their endoscopic instruments and they do what men do. They thrust the whole esophagus open abruptly. They widen it very abruptly. And what can happen, of course? The esophagus might tear. And then it's not small tears in the epithelium, but it can be really large tears that give you peritonitis and that kill you. Little kids die with metastatic cancer. I've heard of little kids dying who had metastatic cancer because they had the dilation, this abrupt dilation of the esophagus through with endoscopic instruments done, and their esophagus was torn. They developed peritonitis and died. Had they done self-dilation continuously, softly, and with controlling the whole thing by themselves, they would not have died. I've known another patient who had a Botox injection in her neck because of muscle trouble in her neck, stiffness of the muscles in her neck or whatever it was. Anyway, a Botox injection, and in consequence of that, she had difficulty swallowing. She couldn't eat over 10 days. And then over weeks, they couldn't even put a feeding tube, a nasal tube, or a feeding tube nasally down her throat because she kept gagging, choking. And in my opinion, what she had was a stenosis, a relative stenosis of the pharynx. Because she didn't use it for swallowing for such a long time, her pharynx became too narrow. The speech therapist said that she was suffering from a disturbance from an opening disturbance of the pharyngeal sphincter, or the pharyngeal muscles that form in a way an upper sphincter of the esophagus. After the Botox went off, the effect of the Botox went off. After that, what she had was a relative stenosis of the pharynx, and one could have helped her by dilating the pharynx, and I suggested that, and it was actually received as a joke. And what happened to her? Well, unfortunately, she was wearing bright red pajamas and also complaining a lot and whining and crying a lot, and but I would be too if I were not able to eat for such a long time. And they simply said it was a psychiatric case and she aggravated her symptoms and so on and so on. But self-dilation would have helped that woman. That's my hypothesis. Maybe totally wrong. And also, dilation is also important in another thing, that is the curettage of the womb, of the uterus. Because the procedure is often even called dilation and curettage. You can't get into the womb, into the uterus, without dilating the cervical canal. And what they do is they use Hagar sticks. They put Hagar sticks, dilators, in there in order to dilate the cervical canal to get into, the womb with their instruments. And I saw this once, and it was even done by a woman, but as I said, women and other gays are the ones that are, that you can expect the least support of when you have trouble with dilation or with widening of hose. And what she did was she thrusted the dilators in and took them out immediately again, didn't even give the skin time to dilate and widen really, and put the next size in, thrusted it in and took it out immediately again, was not softly and didn't give the cervical canal time to widen, and then she did the curettage. And then if dilation is done in that way in medicine, then it's actually no surprise that the cervical canal that the cervix gets incompetent, as they say. I wonder why they don't say incontinent. Then you have an incompetent cervix that doesn't hold the child back. It gives you a miscarriage. You lose the child because the cervical canal is not tight enough, widens too early. That's a risk of that dilation and curettage procedure. But I think it's no surprise if they dilate the cervix in that way, if they don't give it time to widen. So I should also talk a little bit more in detail about my own experience with self-dilation. So in a way about myself, my heroic self-experiment here. As I said, I could cure a chronic anal fissure with self-dilation. The fissure had been present for over years, and I could cure it with self-dilation. I dilated in intervals of 2 to 4 days with a caliber of 40 millimeters, with a butt plug of 40 millimeters, and I could cure it within 1 or 2 months, and it didn't come back as a chronic fissure. And here is what I also found that is maybe the most important result for the whole thing here. So what had given me the fissure was probably a combination of irritable bowel disease and vegetarian nutrition. However, theories about feces are rather vague, and there are not many data around on it. But in this heroic self-experiment of mine, where I dilated every 2 to 4 days with a caliber of 40 millimeters, as I said, I discovered that when I took breaks of about 5 to 7 days, then the anal caliber got narrower again. So when I widened the anoderm regularly, with breaks of not more than 3 to 4 days, it stayed wide, and no tears could be provoked with dilation or with a hard or firm feces. But when I stopped for more than 5 days, the anoderm was vulnerable again, so it had become narrower again. So this is a hint that the anoderm is very malleable, has a very dynamic tissue, has a high or fast regeneration rate. So if you wish to enable your anus to tolerate dilation of up to 40 millimeters, 4 centimeters, this is the diameter of the penis, and this is also the diameter of firm, well-formed feces, then dilate the anus regularly. This is the main message. If you don't do it regularly and don't have regularly hard feces, then it will become narrow again. The other recommendations that are usually given, that is to use a lubricant solution, a water-based lubricant, that does help, and you should use it because it reduces friction between the virile member and the anus. But it only reduces friction if the skin or mucosa of the anal canal is too narrow, doesn't have enough circumference. Then the lubricant will not help, because the reduction of friction is not the same physically as a difference or a deficit in caliber. The caliber is important. Also, Miles et al., one study of the effects on continence of anoreceptive intercourse, the study that looked into the consequences of anoreceptive intercourse on continence. They recommended that people use agents that relax the sphincter before penetration, but this too only reduces friction between the virile member and the anoderm. But it does not widen the anoderm if it is too tight, if it is too narrow. It doesn't help. It does not cure the cause. It does not create additional circumference in the anoderm. And this is, I think, very interesting now. This might also explain a link or an association that was found many times between the use of alkalized nitrates of poppers as a kind of a relaxant or as a sedative or other sex drugs on the one hand, and a higher infection rate for HIV. People repeatedly found an association between the use of poppers, other sex drugs, and a higher infection rate of HIV, higher transmission rate. Now, the causal mechanism here is not at all clear, and it is so unclear even that many AIDS denialists, the people that deny that there is a connection between HIV and the immune deficiency AIDS, that it's so unclear that they said, or that they even claimed that sex drugs cause AIDS, cause the immune deficiency. It's not the virus, but it's these sex drugs that cause the immune deficiency. This is of course rubbish, but there is only there is one mainstream explanation for the association. It's a bit stereotypical, but well, that's not an argument against it, and that is that people who use drugs are also not reluctant as far as other risky behavior is concerned. People who use drugs will engage in risky sexual behavior anyway. That is the argument. They will be so disinhibited that they don't hesitate to do risky stuff. This is the only mainstream argument that would explain it. But there is another hypothesis which could also explain the association very well, I think, and should be tested, and that is that there is a common cause that causes both the use of poppers, both the use of sex drugs, and the higher infection rate, the higher transmission rate. For if two factors, A and B, are associated statistically, then it may be the case that A causes B, or that B causes A, or that something else, C, causes both of them. And this common cause or link between the association might be a relative anal stenosis, which makes sex without sedatives, without relaxants, without analgesic drugs difficult, because it's painful, because it hurts, and it shouldn't hurt. People who have a rectum or an anus of the gods don't have pain during anal intercourse. And at the same time, that anal stenosis might cause, through bleeding through small tears in the anal mucosa, in the anal skin, a higher transmission of HIV. So the anal stenosis causes both that people use poppers at all. If they didn't have pain, then maybe that people who don't have pain during sex maybe don't even get the idea to use sedative sex drugs at all. But because they have a stenosis, it also increases the higher transmission rate for HIV. As I said, it shouldn't hurt, but still, so-called anodyspareunia, something there are not many studies around about, is actually quite common. We saw that about a third of anoreceptive MSM sometimes bleed, and that about 10% bleed half the time to always. They bleed up to always. Now there are 3 articles on anodyspareunia, that is the difficulty with anoreceptive intercourse around, and there they too found that the majority doesn't actually have any difficulty or pain with anal intercourse, but that nonetheless anodyspareunia, that the presence of difficulty with it, is quite common. In 2005, Damon and Rosser found that 14% of their sample group experienced of MSM, sometimes experienced anodyspareunia, had always had it, avoided sex for periods of time, and those subjects thought or reported that psychological factors were the primary contributing cause of their pain. Now, maybe it's in part psychological. Psychology may be a factor, but the main factor is that the anal skin and the mucosa of the anal canal is too narrow. Of course, if you are squeamish, if you press or squeeze tightly, if you're anxious in a way, then this is a factor too. But I think that the main factor is the maximum atraumatic anal caliber, where the skin is responsible for. Now, in an earlier study, 1998 already, this is one of 3 studies on anodyspareunia, the rate was about 12% of the sample group. 12% of the MSM here said that they had somewhat severe dyspareunia, where it was often too painful to continue intercourse. And here participants rated that inadequate lubrication was responsible. Psychological factors such as not feeling relaxed were also responsible. Again, this is a factor, but it's not the only factor, or not even, I think, the main factor. The main factor is lack of regular dilation, of regular physiological healthy dilation of the anus through well-formed firm feces or instruments, or for that matter, regular copulation, regular intercourse. Many people in that mild study, for example, they did not have receptive intercourse very regularly. They found an average frequency of anal intercourse of about 2.5 times per month. That is way too rarely for the anus to stay wide. As I said, the intervals where the anus stayed wide, in my case, was about 5 days, and then it became noticeably tighter or narrower again. I could produce new acute tears when I watched it closely with a webcam. You should get familiar with your anus. Use cameras that have a short focus and see what happens if you feel pain when your anus is dilated. You can also, the giving person in sex can also detect when pain occurs, because there shouldn't even be some kind of sweet pain during intercourse that, well, wears off after a few seconds, or only comes back again once the virile member is drawn back and then inserted into the anus again. This also refers to some recommendations that you can read online, where people say that it is better not to remove the penis once it is in, because if you then go back in, then it will be painful. But if this is the case, then it is very likely that there is a small paper cut through which infectious agents can enter. Intercourse is even possible without these small paper cuts. You should even avoid these small paper cuts through regular dilation. And as I said, the giver can detect when it occurs also. Watch closely. An open mouth and a round mouth and a comfortable moaning. That is a good sign. But once there is really deep animal moaning, we all know that in nature 50% of the copulations are quasi-rapes. If there is a really deep animal moaning, and when people bite their teeth or really distort their faces in almost agony, that shouldn't occur, because that is pain. Once people start biting their teeth or biting on their fingers or on the pillow, then pain occurs and the giver should stop. And the taker should also tell the giver to stop. This may be the point where depression and a lack of self-confidence come in. People who are depressed, who are not really assertive in sex, they don't tell the other person to stop once it hurts. That may be the causal mechanism of depression also. Now, what else is there? Another factor, lack here in the earlier study, 1998, the subjects here also felt that a lack of digitoproctic stimulation prior to penetration was responsible for sex being painful. Now this is also something I experienced, and I think that a lot of MSM, although you would actually expect that they are somewhat familiar with the anus and that they are comfortable with the organ and that they like it, they refuse to do digitoproctic stimulation. My conjecture would be that they are somewhat afraid to come into contact with feces. Now this is also a bit of an intricate subject, but usually, or in the normal case, this is what at least is taught in medicine by some sources. In the usual case, the rectum should be clear of feces. The feces are usually stored in the sigmoid colon and not in the rectum. They only pass through the rectum, so that usually the rectum should not hold any feces, except for when you're just about to have a bowel movement. There are, however, many exceptions from that rule, and yes, there can be feces in the rectum. But you also shouldn't be afraid of that situation. If these occur, you can remove them. You can clean your rectum, have a bowel movement, and remove maybe remaining bits and pieces with your finger. That is not a problem. Nurses in hospitals do it all the time when people suffer from constipation. It's no big deal. And if you're afraid of such a thing happening, please talk about it. Talk about your fears of coming into contact with feces. Because if you don't talk about it, that still adds stress to the whole situation. And your anxiety and your tightness becomes even worse. Be comfortable with it. Say to your partner, well, let me just go to the toilet and check and see whether there's no rocks in the way for you. This may sound disgusting, but that actually shows that you are not something of a coprophile. In that way you avoid contact with feces. People wouldn't kiss with a full mouth either. They would empty it first. So what else did I want to say? There is, of course, a famous person, a famous patient suffering from anodyspareunia. This is also quite interesting, or also helps you when you feel lonely with your condition. There is a famous anodyspareunic, if you wish, and that is the Spanish painter or artist Salvador Dalí. Now, many old psychoanalysts or psychiatrists or biographers think or always repeat that he was somewhat repressed, that he had problems with women, that he was an ego-dystonic homosexual. But this is actually also rubbish. In his not in his diaries, but in his interviews. And it has also been reflected or worked into a recent film about him. In his interviews, and also in his diaries and letters, it is quite clear that he had something of a love affair with the Spanish poet Federico García Lorca. He was obsessed by Lorca, could only think about him and talk about him all the time. And in the interview, he said about Lorca that he, quote, tried to screw me twice, but I was not willing to give in, or something along those lines. Besides, he said, it hurts. Now, it is, I admit, somewhat ambiguous, these words. Maybe they didn't really try it. It was just a first attempt at seduction, and they did not really try the very thing. You can read it like that. But I think the more plausible reading is that Lorca and Dalí did try it, so he was not at all repressed in his feelings. They did try it, but then he found out that it hurts. So the trouble with Dalí was not that he was somehow repressed or ego-dystonic in his feelings, but the problem simply was that his anus was too tight. He had anodyspareunia. But as I said, the solution to the problem is quite simple. Use self-dilation. Even if it seems like a perverse procedure or like a perverse pastime, it's the best thing that helps. And also in many other areas of medicine. If your esophagus is too tight after cancer or other conditions, it helps. Even if you're about to give birth, there are instruments around with the help of which you can dilate the birth canal. that is of course a prudish term, instruments with the help of which you can dilate your vagina, so that thrusting out the baby, there will be of course some cervical pain when the cervix effaces and lets the child go into the vagina. That will be a pain you won't be able to prevent that well, but the pain from the baby coming through the vagina, that you can reduce significantly if you dilate the vagina slowly and gradually with balloons or with such instruments before birth. And there is even anecdotal evidence online where people say that intercourse after birth and before birth was the same for man and woman, because there were no big tears during birth. Episiotomy was not needed, where they do a large cut in the outer vagina so that the baby can pass. And this is also sometimes a very ugly, very bloody procedure. But as I said, don't expect, if you have anodyspareunia, don't expect too much sympathy, especially from women, from other gays, or from the birth thing. If you go to midwives and ask them how you can avoid pain during birth or before birth, then some midwives still find this somewhat outrageous as a request or as a wish, because it is somehow expected that you should accept the pain linked to birth or to sex or to probably almost any human interaction. You should always feel pain. It's always about suffering and trouble. When I talked to my mother about my anodyspareunia that I got also from the chronic anal fissure, she also suggested, don't you think that you need to have an operation done and that might help? And but I was lucky. I could say no. After having seen that ass of my acquaintance, I won't have an operation done down there, at least not for such a minor disease. But now I tell you, it turned out that she had it too, that my mother had dyspareunia as a young girl, or as a young woman. Her hymen was, I don't know what the condition really was, but her hymen was somehow too tight, or she simply had dyspareunia. All my family are very nervous, very squeamish people, and as I said, the psychological factor is also there, and she had an operation done before she could have intercourse. And maybe this is what people who had an operation always want other people to have done, so that they have a scar too. Don't expect too much sympathy and kindness and softness in this area. But the main message is, if you have it, dilate your anus. Skip brushing your teeth about 2 to 3 times a day is often more than enough. And so every 2 to 3, every 3 to 4 days, skip brushing your teeth once and give your anus a good dilation so that it won't tear, because tearing puts you at a high risk of HIV transmission, especially men, because the feces people, the few people that did studies about feces, they found out that, especially in men, feces are in general not very well formed. They shit pudding or broth rather than firm sausages. The ladies have rather firm, well-formed feces, but the men don't have it in general. And so, if they don't have regular intercourse either, be it because they don't feel like it, because they have to study, because they have to work hard, because someone close is ill, is sick, because there is sorrow, then at least regularly dilate it with instruments so that it stays healthy. Don't only take care for the upper end of the digestive tract, but take care of the lower end of the digestive tract also. Skip brushing your teeth every 3 to 4 days once, and instead dilate the anus. Turn your anus into something like a well-functioning vagina of the normal heterosexual population that does not contract or does not transmit HIV/AIDS that easily as in anal-receptive men who have sex with men. We just have to change the transmission route. We have to put the block or barrier there. No need to develop a vaccine, because it doesn't work anyway. So this was the part about MSM, and I will quickly continue with with what causes AIDS in Africa, what explains the general epidemic or pandemic, how that disease can spread in the general heterosexual population. And I think I have found the result of, I have found the answer also there. So see you.